Hello, everybody. My name is Jacob Agamau. I am coming to you live from the epicenter. Welcome back to another QTHealth831 live stream. Today, we're going to be going over masculinizing surgeries. And yeah, we hope that you have questions. And if you want to have them answered, you can submit them into the comment section or the chat of whichever format you're watching us from right now. Thank you for being here. And with no further ado, I'm going to pass it over to my colleague, Haley Gomez, who is going to tell us a little bit about the epicenter. So I will go ahead and do that.
Hi, everyone. My name's Haley. I use they, them pronouns. I work at the Epicenter as the media content creator that consists of video editing, photo editing, social media, and everything like that. The Epicenter has many different programs and other types of resources. One of our programs is our Gente, which serves the LGBTQ plus community of Monterey County. Another one is Friday Night Live. And another one is our foster youth program that provides resources for our Monterey County foster youth. We have multiple resources as far as housing, employment, education, and much, much more. If you would like any more information on the Epicenter, you could go to our website. It's theepicenter.org. And if you want to check out any of our social medias, it's going to be the Epicenter 831. Without further ado, I would like to introduce the main person that will be talking about the LGBTQ plus topic of today, which is Dr. Rose Lovell.
Hey, thanks, Haley. So as mentioned, I'm Dr. Lovell. I am one of the now third-year family medicine resident physicians at Natividad, aka at Laurel Family Practice. They're effectively the same thing. And I'm going to be talking with you about masculinizing surgeries. For those of you, for more information, particularly for trans folks who are seeking to masculinize, including trans men. So welcome. A couple of disclaimers that I do have to go through before we start, because I have, I'm a physician, so I have to say certain things whenever I talk. One is that I've got no financial ties to any specific medical treatment. Nobody is paying me to say any of this stuff. The views that I express are my own. They do not reflect that of my hospital, my residency program, or the clinic that I work at, although I'll point out that Natividad has chosen this year to deck out its lovely Facebook page in Pride colors this year. Hooray! And hopefully Natividad can have a presence at next year's Pride when we can all actually be together in person. I do my best to use the most inclusive terminology, but I just want to acknowledge that not everybody agrees on the right terminology to use. And so if I use terminology that's not to your preference, I do apologize. Feel free to toss me feedback, and I'm happy to adjust the words that I use. And the information that I provide here is intended to be informational only. If you have questions specific about your medical care, really best to talk with your physicians, particularly your primary care physician. If you need help finding a primary care physician who is comfortable with LGBT topics, also feel free to throw us a query. Throw us a question, or you can go way back to our first couple of videos where we go more in depth about how to find one. There are actually more options in Monterey County and in Santa Cruz County and San Benito County than you would think. Also, because we're talking about surgery today, I will be showing medical diagrams of both chests and genitals, but I will not be showing any photos of surgical results. I feel like cisgender people like myself do that plenty, and I don't want to contribute to that kind of a culture. If you need photos of surgical results, if like you're comparing surgeons, Trans Bucket is a great website you can register for to go look at photos and contribute your own. I've also seen plenty of photos submitted by and for the trans community over on the Reddit trans community. So those are places that I'd look, but I'm not going to do them as part of this presentation today. Also, a caveat, I'm a family physician. I'm not a surgeon. I don't personally do these surgeries. And so for a lot of details, it's really best to talk with your specific surgeon, because the details of the surgery are going to matter, and they're going to differ depending on the surgeon, on their training, on their experience, on what new fancy studies have come out. So really, I can talk in generalities, but you really do want to talk with an experienced surgeon for many details. And a little bit of news. So I am a resident physician, and my time in residency, which is the training that we get after we graduate medical school, is coming to an end. And I am slated to graduate from our program at the end of the month, which means that my time as a physician providing LGBT care and providing hormone therapy at Lovell Family Practice Clinic is coming to an end. The last date that I'm currently scheduled to physically be in clinic is June 22nd. And in theory, my time will be done at the end of this month. By the way, happy Pride. I am currently signed to continue on at Santa Cruz Community Health at their East Cliff location. If everything goes well, hopefully I'll be able to start seeing patients sort of around November, assuming that nothing implodes on the paperwork side. In my absence, Lovell Family Practice Clinic will be continuing to provide LGBT inclusive medical care. We will continue, as always, to be doing full spectrum family medicine, which is pediatrics, OBGYN care, including some high-risk OB as well, geriatrics. We can do small procedures and everything in between. We also do provide pre-exposure prophylaxis. And we do provide hormone therapy. So please continue to call Lovell Family Practice. They will still be able to provide care. These monthly events will continue. The next one's scheduled for July. So keep your eye out on the social medias, and these will continue. It's just not going to be officially Natividad, because I won't be with Natividad anymore. So let's dive into the topic. Thanks for your patience. And let's talk about masculinizing surgeries. Some basic requirements, same as before. If you chimed in for our feminizing surgeries talk, then these basic requirements are the same. You must, in general, be 18 or over, or an emancipated minor, or have your legal guardian or parents consent in order to have treatment related to gender dysphoria. You must be able to understand the risks and benefits, in this case of surgery, and express that understanding and consent to the treatment. So if you're having an acute psychotic break, you may not be able to understand the risks and benefits. And so, that becomes a lot more challenging, right? I do recommend that you have access to psychotherapy, but actively participating in psychotherapy is not a requirement. It's just a recommendation. It's also highly recommended that other medical conditions be under a reasonable amount of control. So, that your diabetes is pretty well controlled, that, if you've had a heart attack in the past, that you're on all of the right meds and there's a cardiologist involved, that kind of stuff. And obviously think about fertility, because there's no guarantee. Some of the surgeries I'm going to talk about would make it impossible to have biological children in the future. And others just makes it more challenging. Your mileage will vary. Your experience of surgery or of gender confirming treatment will be different from that of your neighbors. So just understand that going in, your results are going to be different because your body is different. Also remember that if you have California-based healthcare insurance, including California Coast, our managed Medi-Cal service, is an included benefit of those insurances per California law. So what your copay is going to be, I can't say, but the surgery itself is a covered benefit. So let's talk about what surgeries are available. What am I even talking about? So very simply, chest masculinization or top surgery, other forms of face or body masculinization, hysterectomy and ovarectomy, so removal of the other gonads, so female gonads, so to speak, in quotes, metoidioplasty and phalloplasty. Let's go through them one by one. So chest masculinization or top surgery, because it's a lot easier to say. the requirement for getting top surgery is one letter from one mental health provider. They do have to be licensed in the state of California, but that is, you don't have to be on hormones. You don't have to be actively in therapy. You just have to have seen someone and gotten a letter. And you don't have to be presenting as your gender for a certain amount of time. All you need is a letter. In top surgery, this is not mastectomy. Mastectomy is typically, when we say mastectomy, we're thinking of a radical mastectomy, like for folks who have breast cancer. The goal of a mastectomy is total removal of all of the breast tissue. And remember, men, women, everybody has breast tissue in their chests, whether you're lactating or not. And so this is different because the goal of top surgery is to remove enough breast tissue and to shape things in such a way that it's a more masculine shape. And I'll show you kind of examples of that. But if you've seen photos of like a radical mastectomy, it does not have that nice pectoral muscle shape. It's like solidly flat chest wall. Sometimes I have to take muscle too when I do that. So very different kind of surgery. There are two basic types. There are others, but the two basic ideas are something called a keyhole or double incision. And which one is recommended for you depends on how much chest tissue you have. This photo here is that of a keyhole type. In a keyhole is really for someone who has very little to basically almost no chest tissue or breast tissue. It uses a very small incision on the underside of the areola. That's the colored area around the nipple. And then they remove the breast tissue that way. And a shout out to Gender Surgery Amsterdam for these photos because they're great. And they have more surgical examples on their website and more diagrams. The benefit of this surgery is that the scar is very small. It's hidden very well. And sensation is better preserved because, as you'll see in the next type, some surgeries you have to just take the whole nipple off, and that cuts all of the nerves that go to the nipple, and so obviously is going to affect sensation. This has less of an effect on sensation, but it's really only available for people with very minimal amount of chest tissue. The other form is sort of a double incision, is the term that's commonly used. The basic idea with a double incision top surgery is you take the nipple and the areola and you take it off. You also shave down the areola to make it smaller and more masculine. And you cut on the underside of the chest or breast tissue, and then you remove the breast tissue that way. What this gives you is scars that are on the underside, sort of at the bottom of the pecs or where the bra strap used to sit, or where a heart rate monitor, those old school chest straps, where that sits. It will leave you with scars there. They obviously sew the nipple back on. And this is the surgery that is frankly most top surgeries because most people seeking masculinization have been exposed to a whole bunch of estrogen and unfortunately have developed a lot of breast or chest tissue. So this is really the one that will remove all of that tissue. So definitely if you're anything bigger than, I'd say like an A cup for sure, this is going to be more what you're looking at. One downside, so a couple of downsides of this, unfortunately, it's more visible scars. And if you're cutting all the way around the nipple and or areola and removing it from the chest, that does cut all of the nerves. And so it does impact sensation. But you get a much more masculine chest out of it. And frankly, the surgical results can be absolutely gorgeous. So those are chest surgeries or top surgeries. And that's sort of the basics of that. Your next one that you might think about looking at is something facial masculinization or body masculinization. These are fairly rare. I know of one surgeon, maybe two, who openly offer this. There are no specific requirements per the standards of care, I would expect in general to need a letter from a mental health provider, just from what I'm seeing from the surgeons. That seems to be kind of their default. And what kind of things are they looking at? I used this image when we talked about feminizing surgeries. This is sort of a reminder of the differences between a masculine skull and a feminine skull. So testosterone with time, especially during puberty, results in changes in the bone of the skull in particular, as well as the pelvic, the hips, the pelvic bone. So it gives you a sort of a more prominent and a sharper angle to the jaw, gives you a bigger jaw, gives you more of a brow ridge, that kind of stuff. And what facial masculinization, if I can even say the word, seeks to do is to put more tissue in and create that more masculine face. Similar things with body masculinization. I don't know the specifics of the specific techniques. Again, this is fairly unusual, but if you have a lot of face dysphoria and testosterone really hasn't helped you, this may be something worth looking into. Then there's hysterectomy or oophorectomy. Unfortunately, because this is a surgery done for gender dysphoria, even though it is done for cis women all the time, you do need one letter each from 2 different mental health providers, so 2 letters total, and need to have been on hormones for 12 months unless medically contraindicated. That is the recommendation from WPATH. There's a lot of political discussion going on right now about the necessity of those requirements. But the benefit of, at least of this surgery, is that it can be performed by pretty much any OBGYN. I have worked with some locally who have looked me in the face and said, hey, yeah, I can do that for trans folk. So you may even be able to get it without leaving the county. Specifically, hysterectomy is removal of the uterus. And usually they take the cervix with it, because why leave the cervix behind most of the time? Oophorectomy specifically is removal of the ovaries. And then salpingectomy is actually, most of the time you don't hear that term, but it's removal of the fallopian tubes. Most of the time, if we're going to take the uterus and the ovaries, we'll take the fallopian tubes, like they don't serve a purpose at that point. But we're doctors, we like to be really specific, and so those are the terms you'll hear. One of my favorite acronyms is actually for a total abdominal hysterectomy and bilateral salpingo-oophorectomy, which is shortened as TABSO, which is almost Tabasco, which I absolutely love. This can be done in any number of ways, like roll a 20-sided die and you'll come up with all of them. The common ones are transvaginal approach, where they go through the vagina. If you've been on testosterone for a while and you've got the vaginal atrophy going on, they may not be able to do this one as easily just because the tissue is not as stretchy. Laparoscopic, where they put tiny little, like 1 centimeter long incisions in your belly and do it that way. Or the classic way is to do open abdominal surgery, where they do a cut down the middle and they open you all the way up and do surgery that way. All abdominal surgeries have the risk of being turned into an open surgery. We try not to do the open version as much anymore because it makes a big scar and people tend not to like that. But you know, the benefit of hysterectomy or oophorectomy, you don't need cervical cancer screening if you don't have a cervix. There's no more possibility of pregnancy. If you don't have a uterus, you're not going to get pregnant. And removal of estrogen. If estrogen itself is causing you a lot of dysphoria, then removal of the ovaries may be to your benefit. Also, this is a permanent end to vaginal bleeding, because if you don't have a uterus, there's nothing that would be making blood. The downside is, a couple of downsides, is that one, you now are permanently never going to get pregnant. So that has ended your ability to have carry your own biological children. You could save the ovaries, so to speak, and save the eggs and maybe a partner or have someone else carry a fetus for you. But removal of the uterus is removal of your ability to carry children to term. And then removal of the ovaries does tend to mean that you do need to be on hormones for most of the rest of your life in order to maintain that bone health. Okay, and then let's talk about the fun genital surgeries that everybody wants to talk about. So let's start with metoidioplasty, or meta for short, because nobody wants to say metoidioplasty 20 times. Lots more requirements. This is sort of metoidioplasty and phalloplasty, of course, being the equivalent of vaginoplasty. It's going to have the same requirements. So 1 letter each from 2 different mental health providers, 1 letter from your hormone provider or your primary care physician, 12 months of being on hormones unless there's a medical reason not to be, and 12 months of living, here's the phrase, living in a gender role congruent with one's gender identity, big giant quotes, unless contraindicated. So meaning if you identify as male, that you are living as male in your society, that, you know, everyone calls you he, that everybody's using a masculine name for you, all of that stuff. There is a good medical reason to be on hormones for at least 12 months in the case of metoidioplasty, because metoidioplasty relies on your tissues. So the essence of metoidioplasty is the concept of a clitoral release. So with testosterone, the clitoris becomes much larger. It's just the effect of testosterone. But it will still be in sort of that clitoral position. And it's surrounded by a whole bunch of ligaments and a whole bunch of tissue that makes it seem much smaller than it actually is. So a clitoral release is going in surgically and cutting a bunch of the tissue. So if you're able to view the video for figure C, you can actually see a whole bunch of those ligaments. They're kind of showing them to you. They go in and they cut a bunch of the ligaments so that the clitoris can hang more freely, more like a penis. Frankly, at that point, I call it the neophallus, or the penis, because it's a penis. And becomes longer effectively, and hangs in a much more penis-like angle. That's the core of it. Commonly, it also comes with a vaginectomy, also then with a scrotoplasty with implants. So removal of the vagina, and then using the labia majora, the outer lips, so to speak, as the scrotum. So they sew those back together and put scrotal implants in. So it becomes a scrotum. At the same time, using the labia minora, so those inner lips, to make a urethra and make the urethra go through the penis. So these images on the right are showing you kind of those steps. So the blue tube is just them marking certain landmarks for them, the surgeon anatomically. But what you have at the end is a penis with a urethra going through it, with a scrotum, with, you know, little scrotal implants like testes. Now, why would you have a metoidioplasty? So the couple of things going on with metoidioplasty. The length of the penis that you end up with is somewhere on the order of 3 to 8 centimeters. Everybody's going to be a little bit different. But the reason why we recommend that you be on testosterone first is to get that greater length, is to get what the larger clitoris. Average length is around 4 to 5 centimeters, which is sort of 1.5 to 2 inches. There used to be the theory running around that you would never be able to have penetrative sex with a metoidioplasty. Talking to many trans men, that is not actually true. It just varies a little bit by person, by partner, by flexibility, as well as by everybody's weight. With a little creativity, some folks have been able to have some very satisfying experiences. A benefit of the metoidioplasty is that the penis can become erect on its own, and the penile nerves are not impacted. They're not touched. If you notice, if we go back to the actual diagram, everything is kind of, aside from the urethral lengthening, everything else is happening like around the clitoris. So there is not a lot of like the severing of nerves that can happen in other procedures. And then if the person chooses to have urethral lengthening, they can pee standing up. As I mentioned, sort of the core is clitoral release. You can have parts of this procedure and not others. So I've seen vagina-sparing metoidioplasties where you still have a vagina. You can still use your front hole for sex if you want to, but that have that clitoral release. You don't have to have a scrotum with implants if you don't want a scrotum with implants. A lot of these options are fairly flexible. So it's the core is that clitoral release, but then everything else is discussable. And some surgeons will also do the hysterectomy at the same time if you want. Some won't. It's worth talking with your surgeon about. So that's a metoidioplasty. So the clitoral release, the clitoris is the penis. You end up with a smaller penis, but a penis that can become erect on its own. Contrast this with phalloplasty. Same requirements as metoidioplasty, so we'll skip right over this slide. The phalloplasty takes tissue from somewhere else in the body to make a penis. And I'll show you a diagram of what I mean. This is a big set of surgeries. If you're starting from square one of never having had surgery before, it's on the order of 3 to 4 surgeries. They're big surgeries. You can do it after a hysterectomy, oophorectomy. You can do it after a metoidioplasty. There are 2 basic types, and that's the free flap versus the pedicle. The basic concept there is, are you taking tissue from elsewhere in the body, completely removing it from the body, and then putting it back on? Or are you basically taking tissue and twisting it around and leaving it attached as like a flap that's still attached and letting it grow, and then you cut it off from the other part later? So the pedicle is the part that's still attached. That's usually with tissue from like the lower belly or from like the inner thigh. Usually really it's belly. The free flap is much more common. You're going to need tissue from somewhere. So where are they getting the tissue from? I've seen a very long list, but the most common sites are the forearm. So this area right here. Also the inner thigh, also the belly, the latissimus dorsi, which is one of the muscles in the back I've also seen referenced. The list, frankly, it just goes on and on. Yes, the area that is the donor site, so typically the forearm is one of the most common, will have scar. They are removing tissue from that area. It is going to have a scar. But long-term aesthetics, patients are usually pretty pleased with the overall results and don't mind the scar. But something to consider. And then you usually do have to do hair removal on the site that is the donor site. So the forearm, for example, because I don't think most people want hair on their penis. So usually a good idea. These are images showing you kind of what I'm talking about. On the left is what's called a suprapubic phalloplasty. And this is sort of an example of a pedicle type where they use a flap of tissue, but it stays attached to where it was. So we don't cut all the blood vessels, we don't cut all the nerves, it kind of stays attached to where it was. Versus, this is a diagram of the forearm flap phalloplasty, where they take tissue from the forearm, remove it from the forearm, and then they make a penis out of it. These are big surgeries. These are really big surgeries. Here is an example of, this is from Belgrade. We used to have a running joke that the best penises came out of Serbia. So a lot of the information about phalloplasty actually comes out of Serbia still. So this is from the Belgrade Surgical Center. Much appreciate their just sharing this stuff online. So their first stage surgery would be 7 to 9 hours in 3 different surgical teams, where they do the hysterectomy, they do a vaginectomy, they remove the vulvae while they're there, and they used a section of back, so the latissimus dorsi muscle, and transfer it. So they do the actual phalloplasty itself, so the penis part. They do a scrotoplasty, so create a scrotum with implants. They do the urethral lengthening, so using tissue from the genitals They use that to make a urethra, all in one surgery. It's a huge surgery. And then they do a second stage where they basically work on the urethra and they shape the glands of the penis, because typically they do that first stage and the penis is just a tube, because your body's really got to heal from that. It's a big surgery. But then they go back in and they refine. So the second stage in this case is refining the glands, and then, you know, also putting in a prosthesis, and I'll talk about that. And then stage 3 is sort of an as needed, and they do all this other stuff that basically aesthetic refinements. So phalloplasties can be any size, which is the benefit of the phalloplasty. If it's really, really important to you for your dysphoria that you have a penis that is literally a foot long, you can have a foot long penis. But it does need an implant in it in order to become erect. We use implants in some cis men who have erectile difficulties, for whom things like Viagra don't work. So we have implants, they exist. We've been using them for a long time, but you would need an implant. The sensation, from what I hear, is preserved. It's not going to be like exactly the same as it would be for a meta, but they sort of fold in the clitoral tissues at the base of the penis, and the brain is a very plastic thing. So yes, men who have phalloplasty do have sensation and do have orgasm and do, you know, have sexual pleasure. And because of the urethral lengthening, they can also pee standing up. The phalloplasty, also because it can be a larger size, can help a little bit in the phenomenon of needing to pass, quote unquote, depending on what their social situation is. So those are the basic types of surgery. We talked about top surgery, facial or body masculinization. We talked about hysterectomy or an oophorectomy. We talked about metas, and we talked about phallos. What are some of the risks of these surgeries? I talked a little bit about some of them, but I'm a doctor. I got to talk about risks and benefits. This is kind of my job. So there are some universal risks of surgery. Anytime that we do anything that involves cutting the skin has a purpose. It's there to protect you. So anytime we cut it, there's a risk of infection, bleeding. Anytime we cut skin, there are lots of little tiny nerves, and we try to avoid the big ones, but sometimes we hit them. So a loss or change in sensation. There can be problems with wound healing, so including dehiscence, where, you know, we sew it back together and it breaks apart, or death of tissue, especially that risk is even higher if we've been, you know, taking tissue off and moving it around. The accumulation of fluid or blood, so what we call a seroma or hematoma, basically like a big gnarly bruise. Scars, anytime we cut skin, there's a chance of a scar. And in severe cases, that the scar can become kind of overgrown like a fibroid. Anytime that we are doing, most surgeries require general anesthesia. We put you to sleep, we put a tube down your throat. Anytime we do that, there are a bunch of risks. It's pretty stressful on the body to do that. So there's risk of heart attack, there's risk of stroke. There's risk that the medicines we give you, you'll have a bad reaction to it. There's risk of infection and other problems from the breathing tube. Any time we put someone under general anesthesia, there is the risk of death. It is rare, but it is a risk. So I gotta say it. Specific risks of the specific surgeries are pretty similar to the general risks. I've listed a few here, and I'll talk about them. But really, I also would talk with your surgeon. Your surgeon, when they go through the conversations with you, they should talk with you about risks and benefits, and of the different techniques, but also the specific risks of the specific surgery. The only person who can technically consent you, meaning talk about this and get your consent for the surgery, is the surgeon. So you should feel free to ask all the questions with your surgeon. If you think of more, call them, have them call you back. but you should feel like you have a good understanding of all the risks that are involved. Some specific risks of some of the specific procedures, anytime they do what's called a urethral lengthening, meaning they're taking tissue from elsewhere to make the urethra longer, usually to go through the penis, there's a risk of urethral stenosis and stricture, meaning we have, in order to do that, we had to move that tissue around and we kind of had to poke it and like put a needle through it to sew it together and stuff like that. And so there's a chance that the tissue will basically go, ew, I don't like that, and get really narrow and make it hard for urine to flow. And so usually we treat that with what's called dilation. So you basically, the same as with a vaginoplasty. If the tube gets narrow, you stick something in the tube to make it bigger, like putting an earring into an earring hole where it's gotten really narrow, and you put something in it to hold it open. It's a little bit like that. Anytime that a surgeon touches a urethra, there's always the risk of incontinence. Pretty rare. Urethral stenosis itself is not that rare, but actual stricture needing like really intensive therapy is unusual these days. And then anytime that we put in penile or scrotal implants or breast implants or implants of any kind, there's always the risk of infection with a foreign body. And there's the risk that that foreign thing that is not you will kind of erode through. Again, very rare, but it's a risk and we got to talk about it. And then all of the other risks that I talked about, difficulty with sensation, yada, yada. And then this is just reminding you, talk to your surgeon. It's your surgeon's job to talk with you about the specific risks and to understand the specific risks of their specific procedure. So I can only give you generalities, but they'll give you specifics. How do you prepare for surgery? This is generically true, but got to go through it again. So to reduce your risk of problems during surgery and to really maximize the possibility of a good outcome, these are things I recommend. Don't smoke. Do not, and I mean tobacco, not the marijuana, but the tobacco. Don't use any tobacco products specifically. If you do smoke tobacco, you need to quit at least 2 months before your surgery. Basically, in order for your body to rebalance itself and stop making too much mucus in your throat, which it will do, in order to make anesthesia safer. Tobacco specifically makes it harder for your wounds to heal. Not to mention raising cancer risks and all the other stuff, but you'll have a better healing time and a better aesthetic result if you quit. Exercise regularly, at least 30 minutes, 3 days a week. The more that you're able to get some good exercise in, the better blood flow you'll get, the better aesthetic results, the less chance of bad things. Eating a balanced diet, variety of food, mostly plants, little to no added sugar. Only have pixie sticks once a month instead of pixie sticks every day. That kind of stuff. What every doctor has always told you, but we actually mean it, as hard as that is, do your best to maintain a healthy weight. I should note that some surgeons do have a requirement that a patient be sort of a specific BMI. And that's because the heavier that you are, the less good aesthetic results they have and the harder a surgery it is to do. So the closer you can be to a healthy weight, the easier the surgery, the cheaper the surgery, the better the outcome all the way around. And not just because it's easier and cheaper, but because the blood flows to the areas better. And so you heal better. And then if relevant, always, always, always remember to protect against sexually transmitted infections, get tested regularly, do all your good stuff there, and remember to get the blood tests that your doctors recommend and take the medications we recommend too. We like that. So that's the core of my presentation. And I'd like at this point to move on to questions. I know that we did get a few questions and I really want to dig in and make sure that we answer them for you.
Absolutely. First, I do want to point out how called out I feel about pixie sticks every day. But thank you for that. Also, I did want to show you the shout out that you got from Dr. Tani saying, thanks, Dr. Lovell. This is great.
Hi, Fran. Love you too.
And yeah, we did get a few questions, and I did get one in the chat that asked, do you have any insight into considerations for top surgery for trans men navigating eating disorders, particularly anorexia?
Oof, yeah. I think that my biggest thought would be making certain that you take care of your mental health. Most of the BMI restrictions that surgeons talk about are preventing against obesity, not the other way around. My primary consideration as a family doctor is, but how are you doing, and are you mentally okay, and how can we support you and make sure that this eating disorder doesn't flare up again? I don't think that there are any specific recommendations other than making certain you have a really good nutritional status. So if you're still having issues with disordered eating and are not eating as much as a doctor has recommended, there's always the risk that you'll have a nutritional deficiency, and not having the right nutrients can really make healing difficult. So the best way to get your nutrients is through food, absolutely, hands down. If that is a real struggle for you, understand that surgery is very intense. It's a little bit like running a marathon, and your body is going to need more calories during surgery and after surgery in order to heal. So you are going to have to increase your caloric intake. And even if that is stressful for you, that's something to understand. And you need to have enough nutrition. In particular, zinc and vitamin C are often used to help wounds. So you could consider taking a multivitamin on top, but really you got to have those calories to help. So I really would be keeping your mental health professionals in the loop.
Thank you for that. It looks like we got a follow-up. Is BMI a hard line? The person has always been heavy and outside their normal BMI, even when they were a college athlete.
And this is a really common challenge for those of us who are gender and sexual minorities, or in particular, those of us who are also other kinds of minorities. Insert a long-running joke about women who have sex with women being obese here, but it's a lot of us are on the heavier side. A lot of us are, and it's from that stress. I have not heard of anything being a hard line. Some surgeons are pickier about it than others. I would hesitate at a BMI of 40 or greater, just because the risks do go up at that kind of point. A BMI of 40 or greater is about the point where we start thinking about recommending bariatric surgery. You actually medically qualify at that point. But if your BMI is more like in the obese range, sort of 30 to 35, I haven't heard any surgeon specifically be like, no, I will never do it. But it is worth talking. Different surgeons have different restrictions, and some of them are more hard about it than others. And that it's also changed over time too. So I would ask the surgeons. Yeah.
And I just want to point out that I'm glad that we're getting in-person chat questions right now, because we lack that sometimes. So thank you for everybody that has submitted questions. I have another one that we received by email. If I have PCOS or other hormone-based conditions, can I still access hormone replacement therapy?
The easy answer is yes. And by the way, with the live comments we're getting, if I did not completely answer your question, please let me know and I can attempt again. So for reasons that we don't understand, trans men and trans masculine people have a higher rate of PCOS than cis women. And we really don't understand why. This is before we do hormones for them. This is before everything. We just don't know yet. So yes, you can still get hormone therapy. In fact, it's sort of, you start off in a good place because you have all this extra testosterone, but natively. So, hey, cool. But yeah, absolutely can still get hormone therapy. The only reasons why I would not consider giving someone hormone therapy, if they're pregnant, if they are actively psychotic. So that I cannot tell that you understand the risks and benefits. And at that point, I would probably call in my more mental health oriented colleagues to help us sort out the situation and make sure that we are doing the right thing by you. And active hormone sensitive cancer, so active estrogen sensitive breast cancer, for example, it would kind of be bad of me to give you estrogen or testosterone in that situation, because that would be bad. That would be very bad. So those would be my absolute reasons not to. Everything else is flexible from my perspective. We would just want to look into controlling it.
Awesome. And another one, I think it was covered in the presentation, but we may as well reiterate for the question, is do I have to be on T to get top surgery?
And the easy answer is no, not at all. There's no recommendation. And from my perspective, I see no medical benefit of you being on testosterone for top surgery. As far as I know, it does not improve the outcomes. There are lots of people who are non-binary, who are neutroi or androgynous or otherwise somewhere in the NB spectrum, who don't want testosterone, don't need testosterone for their gender dysphoria, but still need top surgery because they've got a lot of dysphoria about their chest, and they're absolutely able to get top surgery. There are actually, there's a whole bunch of surgeons locally, so you don't necessarily have to go up to San Francisco for surgery either. SC trans, that as in Santa Cruz trans, so S is in Sam, C is in, I don't know, coyote. I'm terrible at those. Trans.org has a great list of surgeons sort of local to the area. I know of 2 groups who will take CCAH, but if you look at the websites of the surgeons, then they will specify what kinds of surgeries they do, as well as what insurances they'll take. And at that point, you can just talk to your primary care doctor for a referral. So also, by the way, you don't have to go all the way up to San Francisco.
Good to know, because like a lot of people sort of operate under the impression that they have to go out of the general area to access these things, but we have them at home, you know?
Yep.
One more question. If you have top surgery, do you still need mammograms or any sort of chest cancer exams or anything of that sort?
And this one's a lot harder to answer. The quick and fast answer is we don't know yet. As I mentioned, it's very different from a radical mastectomy. There is still breast tissue there, which could, in theory, over a lifetime, become cancer. Your risk is much lower after top surgery than it was before top surgery because there's less tissue. And so there are fewer cells. And so the chances of any one cell going bad is much, much lower. I would imagine it'd be very technically difficult to do one after top surgery. I sort of cis male breast cancer is so rare that frankly, I've never seen it. It does exist, but we don't do mammograms for them. So I would not lean toward doing a mammogram after top surgery or doing any kind of breast cancer screening, with the caveat that if you have a lot of breast and ovarian and prostate cancer in your family, meaning your mother, father, sister, brother, like your what we call a first degree relative, so not your grandparents, not your aunts and uncles, but your actual parents and siblings, if you know them, genetic parents and siblings, I should say. If they have cancer, especially at early ages, that is something you do need to talk to your doctor about. I think most of us have heard of the BRCA gene, the BRCA gene. And that may be a reason to think about doing screening or to think about doing the surgery differently. So that is something I would think about and talk with your doctor about, preferably before surgery, because that way they can actually remove breast tissue and create that more masculine chest in a different way. Like I would do a mastectomy personally, would be the medical way that I look at doing that. But I would assume your risk is lower, but I don't know for sure after a top surgery. So I think it's reasonable to kind of follow my rule of thumb, which is in general, know your body, and be able to tell if something changes. So you don't have to do, like, if you have a lot of breast tissue, you don't have to do a monthly breast self-exam. We actually don't recommend doing that anymore. They recommend against teaching it. Instead of that, what I recommend is that you know your body. So you don't have to check all of your skin once a year, but check your skin enough, look at your skin enough to tell if something changes, and then talk to a doctor about it. So that's my basic strategy.
Thank you for that. All right. Well, we're coming up on the end of this. I want to thank you, Dr. Rose, for all of your help and everything that you've done for this program. It's just been amazing. We also do want to stress that we want to hear from you and what topics you really want to hear about. We really do, or we really would like to continue doing these live streams because I think they're so beneficial to our community and just sort of reducing stigmas, just providing accurate information, something that isn't piecemeal, something that isn't just off of what the truth is. It's very, very easy to search on the internet and find incorrect information about our health, and it feels good to be able to be providing this to the community. So let us know.
Yeah, no, for sure. And I can say, even having gone through medical school, like, how much information did I get on LGBT health? On average, we get 4 hours worth of education. So your chances of talking to most doctors and getting a good answer, and I just went through medical school recently. This happens to be a passion of mine. So I care about our community. I want you to have the information so that you can advocate for yourself if you need to. I'm doing what I can on the doctor side to try to make sure you don't have to. But in case you have to, that's why I do this. Our next presentation is slated for July 8th. At the same time, we'll talk about non-binary related health topics, kind of try to zone in on sort of more of those things, like puberty blockers, for example, which can be really helpful for those folks, and sort of, non-standard, big giant quotes, but some of the more interesting surgeries, things that may be more helpful for non-binary folks. And then after that, we're going to kind of figure it out. I'd love to hear about what times work too, because my schedule just opened up.
And we're very happy about that too. You should go on vacation. You should go have some fun. It's been a while, right?
Yeah. Happy Pride Month.
Yes, happy Pride Month. Thank you all for tuning in today. And like I said, if you want to reach us, you can do so at, do I have it? No, I don't. Okay. On Instagram, we are at QTHealth831. And if you want to reach us by email, it's QTHealth831@gmail.com. We take questions there, or on Instagram DMs. Any way you can reach us, please feel free to do that. We're just very excited to continue this. And I do want to thank Dr. Rose. I want to thank Haley and my supervisor, Sam, as well. And what else? How are we feeling about things opening up now? Like, it's sort of...
Oh, more vaccines. Everybody needs to get vaccinated, please. Okay, thanks. That's the major thing. Excited, nervous. The case rates are much, much lower. I just did a round in the hospital recently doing mostly inpatient work, and oh my Lord, it's so much different than it was back in December. That being said, we are still seeing new cases, much fewer than they were, but we are still seeing them. I think when I last looked at Santa Cruz, it was like 60 active cases. So 60 people in the county having COVID is not zero. So I would still wear your masks, which is still required by the county, even though the CDC says you don't have to if you're vaccinated. I personally wear a mask still. And I'm still waiting to go out for a lot of social things because it's still out there. It's still being spread, much lower rates, but a non-zero chance. So wear your masks, get vaccinated if you haven't. Santa Cruz Community Health, I know, is doing vaccine clinics. I know that Natividad is doing massive vaccine drives. I know that with Lovell Family, it's getting a lot easier to get it. So get your vaccines. Besides, then you can hear the 5G. No, wait, no. You know, they are, in the grand scheme of things, so much safer than getting COVID. Please get it. And slowly but surely, the world will return to normal.
Mm-hmm. And I think we all sort of just need to keep an eye on our mental health when it comes to the transition back in. Recognize that it's okay to feel uncomfortable about it, because we're all going to, unfortunately. It's been a long time since we've been able to congregate in a way that feels safe. And I look forward to the day, but I know it's not anytime soon, that it's not going to feel weird. So
yeah.
So yeah,
I was walking through town the other day and someone walked like within 2 feet of me without a mask, and I was like, use my stethoscope like a cross, like, no.
Yeah. It has been nice going on like little walks when I know nobody's really out and about, and just not having the mask on and feeling the wind on this part of my face. Like, it's so different. But
for sure.
Yeah. In any case, thank you all for viewing this, and we hope to see you next month on the 8th. And yeah, with that, happy Pride. Take care of yourselves. Continue wearing your masks. Wash your hands. Be nice to each other. Be thoughtful. And
eat fewer pixie sticks.
Eat fewer pixie sticks. We can leave on that one. Have a good evening, everybody.